So because we have quite a few questions, so let me fire them on. There is a question from Dr. Tariq Galbaya, who is a consultant in the UK and who is a member of our liaison committee. He's asking Professor Johnny Awad, do you think there is, do you still think there is some value for surgery in endometriosis, endometriomas, or do you think there is no place for surgery at all?
For unilateral endometriomas, right? The question is unilateral.
No, he's saying, is there any? Do you still think that there is some role for surgery in endometriosis?
Oh, I think if patients with endometriosis come with symptomatic disease, I think the symptoms will impose on us some form of surgical intervention. Now, one way to do that, if we feel there is a significant risk on the ovarian reserve, would be to try to stabilize the pain and then try to collect eggs and cryopreserve them before you go for surgery. So there are times where the surgery imposes itself on us. There are times where we can maneuver by cryopreserving oocytes before we go for surgery, because certainly the impact of surgery is significant on ovarian reserve.
All right, there is another question from Professor Yasser Abu Talib from Ain Shams University, and who is also a member of the Egyptian Representative Committee, the previous one. What about an endometrioma of 7 to 10 centimeters, bilateral endometriosis of 7 to 10 centimeters? What do you do about that?
Well, if this is an endometrioma that's been stable, in our experience, we tend to leave it in and simulate the patient.
Yeah, all right. I quite agree with you. All right.
In the past, Professor Salam, when we were training, we used to do aspiration of these follicles just before we start stimulation.
Yeah.
And we thought that that will make it, maybe improve the ovarian response, or maybe make them more accessible to aspiration. But then with some reports warning us from abscesses and pelvic infections and all of that, we stopped doing that.
I think anybody who has worked in this area knows very well one case of tubal ovarian access will let you not do it again. And I think Professor Abulgard maybe would agree with me on this point.
Yeah, sure, I agree.
It's really, yeah, can. Okay, from Professor Abu Bakr Nashar from Egypt. What about the use of antagonist protocol in endometriosis? And if the stage affects the selection of the protocol? I think this is from Professor Awad.
I'm sorry, the question is for antagonist protocol, right?
Antagonist, yeah.
Yeah, I do not think there's a difference in whether you take whether you use antagonist or agonist for endometriosis, since in any way we have no proofs really that agonist, even lung suppression, would be helpful in any way. I think it all depends on the AMA. If these women has a high AMH, the best way to go is to go with an antagonist, even in the presence of endometriomas and endometriosis.
Yeah.
I don't think it impacts your decision.
Professor?
There is a,
Professor?
Yeah? Go ahead.
This is a comment to Johnny. It drew my attention with your comments about the studies on endometriosis and surgery. You said that probably these workers or these authors, they might present only the good results of their work. However, those who have not shown their results, probably for lack or experience, etc., I don't know with it. So this is not really clear. However, I agree with you that touching the ovary for all this kind of endometriosis, it will end up by reducing AMH. However, we have seen many lectures and lectures about the surgery and endometriosis. The question is, who can judge? Who are the skilled surgeon who can perform the right job to treat endometriosis, at what stage, and is going to end up also with reduced AMH with these patients?
I think, Michel, I think what you are alluding to is that people who publish tend to be coming from highly academic and specialized centers. So these people who are highly skilled are telling us that the AMH is reduced significantly. What about the common gynecologists with lower skills? This simply means that the damage could be even worse. And I totally agree with what you said.
Well, thank you very much.
Nice.
I think there is a question for Professor Abulghar. How many days are needed to shift from agonist to antagonist if we want to have the advantage of agonist trigger? I guess this is for patients with polycystic ovary syndrome, yeah. So if you are using agonist, so how many days are needed to shift from agonist to antagonist? I don't know if we can do this.
Well, for me, the question is not very clear, but the agonist dose is one bolus, which is given the day you want to trigger ovulation, and this depends on the level of E2 and the number and the diameter of the follicles.
Yes, but if the patient has started on agonist protocol, then she cannot have the antagonist trigger.
No, she can. No, she cannot. I mean,
she cannot. Yeah. So I think the question is that we cannot do this. Okay.
Professor Abulghar.
Yes.
Excuse me, Hassan. Professor Abulghar, I loved your presentation. You know what? You know, I have always been thinking over and over of all that show of technologies in assisted reproduction. And then with your presentation, what you have showed us, that there is absolutely many abuses in these techniques, whereby is affecting psychologically and socially the couples. So I wonder why we have abandoned some basic practice in infertility, and we run for these kind of technologies to offer what? To offer a certain number of pregnancy rate, which is not, wow, an amazing one. So I really like you question these techniques, whether we are abusing or not, or whether we should filter out and narrowing the selection that we have to offer to our patients, taking into consideration the psychological and the social and the economical effect on the couples.
Thank you very much.
Well, thank you very much, Dr. Michel. I would like to give a message that we should concentrate on a basic, very, very strong and highly monitored IVF laboratory, basic stimulation protocols, and every lab and every IVF center should not bother himself by all these techniques, just concentrate on the basic things, and he will improve the results.
Okay. Now, let me concur with what you said. I think with the introduction of vitrification, that is the ability to cryopreserve everything that comes out of this cycle. You return the fresh embryos, but you do not lose what's remaining. I think that is the major impact on what we do today. With a good vitrification program, it simply puts off all the other ways that you discussed. Because this way, you know that you're going to utilize all the embryos, you're not going to waste any, and therefore the process of selection, which is usually at the expense of some of those healthy embryos that are going to be selected out of the process will be preserved, and the overall cumulative pregnancy rate will be much higher than any kind of screening test you ever do. So I think the single most important breakthrough that made all these screening tests futile is proper vitrification of the remaining embryos. You don't lose anything.
I agree.
And by the way, I would like to congratulate you on the analysis of the meta-analysis on the long-term use of GnRH agonist in endometriosis. And I would suggest that you publish a new meta-analysis excluding these studies, and maybe you can find some other data in the literature. And I will encourage you very much to publish a new study on new meta-analysis on this.
Okay, Professor Abulgar, you probably know that this meta-analysis is our meta-analysis. It's our Cochrane review. So this was an old meta-analysis from 2006. There is a new Cochrane review which has appeared this year, and which has addressed these things, and I think Professor Awad knows that those do not affect the live birth rate. But the thing is that there are very few studies, and also the studies are not, there are studies on 3 months, 6 months, there are studies using different sorts of there is studies mixing mild, moderate, severe cases of I join you in asking Professor Awad to do this this study and this new. I guess Professor Awad has seen the new Cochrane review, which just appeared recently. The update.
Yeah, and actually, we have a registered. Yeah, we have a registered ongoing randomized trial over here, and it's ongoing. We just put it on hold because of COVID, but we're comparing 3-month suppression GnRH agonist with the regular protocols. And so far, the preliminary data will tell us there's no difference. So we have a ongoing randomized going on.
Yes. Now, we have a question for Professor Abulgar from Dr. Aysin Aktubyan. She's from Turkey. She's asking whether the antagonist trigger in a fresh cycle has a bad effect on the endometrium. And I think the answer is probably yes. Yeah, it's up to you to answer.
Sorry, I couldn't hear you.
Effect of GnRH antagonist, the antagonist trigger. If we use the antagonist trigger.
The agonist trigger.
The agonist trigger, sorry. The agonist trigger, does it have an effect on the endometrium?
Probably it has an effect of the endometrium because freezing these embryos will have the same outcome if you trigger by HCG or by GnRH agonist. The problem is transferring the first cycle only.
Yeah, so there is another question about controlled ovarian. Yeah, there's another question about controlled ovarian stimulation in patients who have non-synchronized antral follicles. So some of them less than 5 millimeters and others more than 5 millimeters. Is there any special controlled ovarian protocol, stimulation protocol that you would use in these patients?
Well, this happens more often with the antagonist protocol. It happens less often with the agonist protocol, where you will have a cohort of follicles which grow together, and probably this phenomena will be much less. So if it was antagonist, shift the agonist protocol.
Yes, sir. There is a question from Dr. Michel Assad. Are there any studies on early embryo transfer within the first 48 hours after egg collection? And I don't know if anybody has an answer, but I do have an answer, because there is a paper by Ian Kraft, which was in the Lancet very early, maybe in the 1980s, where he put his embryos after 24 hours when they're only 2 at the probe nuclear stage, and he achieved many pregnancies. But people have stopped to do this because in this case, people used to put everything, all the embryos. So then, so there is nobody doing this now. But there are cases, and we do actually have at least 3 cases where we had to put the for logistic reasons, we had to put them back, and they are pregnant. So these are. So if anybody has another answer, please do. But yeah. Okay, there is another question. What is the cutoff age for a lady to try an IVF pregnancy?
Well, this is for me, the question, or for whom?
For your
for
good
everybody?
self, for the godfather.
There is no cutoff age, but we should know very well. No, we should know very well. From the South data, from European data, any woman who is at the age of 43 and more has chances to have a live birth baby is close to 0. Very, very, very low pregnancy rate. We don't like to admit patients above the age of 42. And we are very careful about counseling patients at the age of 41 and 42, and they must have some reasonable AMH to do this procedure.
Yes, sir. Okay, another question from Professor. You want to answer, Professor Awad? Please do.
Yeah, I support totally Professor Abulgar. I'm going to put it in a different way. Now, there are 2 different reasons for success with IVF. One is quality, which is related to age. In other words, it is the percentage of euploid embryos that is in relation to age. So a woman who's 35 years of age, out of every 2 embryos that look good morphologically, 1 is aneuploidy. It's someone is 45 years of age, out of every 7 embryos that look perfectly well, 1 is euploidy and 6 to 7 are aneuploidy. So that's the balance. The more you have embryos, the more you have the probability of finding that euploidy embryo. And so that's a balance, and that for the age factor alone should be taken in the context of AMH and number of follicles at the same time.
Yes, sir. Okay, there is a question again from Professor Abu Bakr Nashar, who you probably know has the most presentations online. He's #1 in the world. He has, I think, 250 presentations or something of the sort. He's asking Professor Abu Bakr, live birth rate declined in the USA and Canada from 2010. Due also to industrialization of IVF for the different reasons. What about live birth rate in Egypt? He was asking. Do we have data in Egypt? Is it declining also in Egypt?
Unfortunately, I mean, in Canada, the shift from double embryo transfer to single embryo transfer was a clear cut point for the drop in the pregnancy rate in Canada. It could be other causes, but that was the main clear cause. In Egypt, unfortunately, very few IVF centers send their data for the Egyptian registry. That's why the Egyptian registry is have only very small number of cycles compared to the real number. So nobody can answer this question, actually. Nobody has the data.
Okay, yes, sir. Another question from Dr. Aysin Akdugan. She's asking probably, what is your idea about adenomyosis? What kind of therapy would you choose if you're doing IVF for adenomyosis? And I think it's for the whole panel.
Well, adenomyosis is a catastrophe. Actually, whatever you do, the prognosis is very poor. And there are data which suggests that you can use progesterone, you can use a long-term agonist for a number of months before you start. But generally, all types of surgery are not very successful. There are many types of surgery designed, which none is very successful. So it is really a problem. And if you have adenomyosis, you will have, by all means, very low pregnancy rate, or much lower pregnancy rate than your regular pregnancy rate.
Any insight, Professor Risk? because we also have many questions for you. We're not going to be late, but we have a few questions for you.
Yeah, well, adenomyosis, I mean, it really depends on the increase in size of the uterus.
Any insight about adenomyosis?
Yeah, I mean, if the uterus is increased significantly to a huge size, then this becomes really very challenging. If it is diffuse, I mean, or nodular, and if it is huge or small in size. The small in size is mixed results. I mean, you know, the small in size mixed results, that some of them do well, some of them do not, and there are no certain criteria, like some of the ones still do the same like the others. Where they increase in size significantly, you have a uterus that is palpable up to the umbilicus, then you don't know what to do, because if you, and we have done lots of surgeries for those with not so great results in terms of achieving a pregnancy, because you end up disrupting cavity and having other issues with the so the uterus is moderate in size and diffuse, and they have a good ovarian reserve, we give them an adjuvant. If the uterus is moderate in size and is diffuse, and there is no ovarian reserve, we do not use any suppression before.
Okay, thank you very much. There is a sound in the background. I don't know where is it coming from, Dr. Mina, if you want to check. A question from Dr. Mohammed Al-Dib. I don't know if it's Mohammed Al-Dib or Mohammed Al-Dib, to Professor Johnny Awad. If accidentally an endometrioma is aspirated during ovum pickup, do you prefer freezing all embryos and not transferred in the first cycle?
No, I do not think so. I think the lab would be warned to do several washes, and can proceed regularly with fresh transfer.
And then, okay, Dr. Sarah Shaguri, she's asking about the Cato protocol. What is the Cato protocol again? And I think it's the Cato, Dr. Cato from Japan. He uses clomifene. Is that right, Professor Abulgar, Professor Rizk, Professor Awad?
Yes, he used clomifene, and in some cases he had very small doses of HMG.
Yeah.
And he has very small number of oocytes retrieved, and he transferred only one embryo at blast stage.
And his success rate?
Well, I have to, there are some publications which shows very high pregnancy rate. But if you look at the Japan pregnancy rate, it is the lowest out of all countries, and they are all using the Cato protocol. Selected publications of a small number of patients, I don't think it really matters. You have to look at the whole year or all patients or big studies to really get the right picture.
Okay, thank you very much, Professor Abulgar. There is another question from Professor Abu Bakr Nashar. What is recommended as an ovarian reserve test in endometriosis and endometrioma? Is it which is the better ovarian reserve test, AMH or AFC? I guess this is for Professor Awad.
I think
which one would
I would go with AMH probably, because it's easier to measure.
Yeah, it can be done any time of the cycle and so on. Okay, Dr. Rasha Muhammad Taha, thank you for an amazing webinar. What about the surgical interference in cases of endometrial polyp? I guess, but that's...
You mean the presence of a polyp, does it impact endometrial implantation?
Yeah.
Right? Yeah, I think there is one single randomized trial that showed in IUI cycles that the removal of the polyp would improve the outcome of an IUI. And in that particular study, many patients got pregnant at a 3-month rest before the actual transfer, semen transfer. But I'm not aware of any study in IVF. Most of the studies are simply non-randomized, and that shows that if the size is less than 1.5, right? Am I wrong? It does not impact implantation.
Yeah, so small ones.
But these are non-randomized.
Okay, another question from Dr. Khalid Nomrosi, a fellow of the Royal College and one of our dearest colleagues in Cairo. My question to Professor Awad is freezing all and using agonists before transfer, does this increase the success rate? Can you use the for the endometriosis, would you, if you do the agonist protocol, which you probably do, would you freeze and transfer in the following cycle? Does this increase the success rate? Freeze all? I mean, is freeze all is good, a good policy in endometriosis? Probably the question is.
Yeah, I think there has been some groups that collect all the eggs, the embryos, they freeze all the embryos, they suppress the cycle for 3 months with birth control pills, and then they return them later on. I think there's a group from France who does that, but there's no randomized trial to support such practice. There are many who do that on the basis of their own experience, no randomized trial to support that.
Yeah, and of course we know the work of Shapiro in Las Vegas. He freezes all for all. Now the questions for Professor Risk. This is Dr. Hassan Awad. I don't think there is a relation with Professor Johnny Awad, but anyway, do you recommend the use of antioxidants as an adjuvant in all cases of IVF?
We do recommend the use of antioxidants. However, I think the scientific approach would be to conduct prospective randomized trial and to what Michelle suggested is to standardize what are we talking about. So if you're using a statistic and I'm using, are we doing the same study? Not only that, could there be a harm from overusing certain amounts? For example, in the old days, we used vitamin A in a huge dose. And then 20 years later, we find that high dose of vitamin A is very harmful. So we change our mind. So I think there is two issues here. Prospective randomized control trial, before you put guidelines, you have to consider that. Because there could be other issues that we have changed. However, I'm telling you, we have not intentionally changed anything in this period of time. The second thing is to standardize the amount of antioxidants and the kind of antioxidants. Are you using selenium? Are you using zinc? Are you using molybdenum? Are you using melatonin? And so on. Dr. Abu Wahab,
I have a question to Professor Rizk. The paper, the very elegant paper, which you mentioned about, which was published by David Gardner.
Right.
Of course, if this proves to be right, I mean, this study, this is a great achievement in the culture media and in the pregnancy rate. But I have some problem with this study because randomization of sibling oocytes, there could be bias on day 3 choosing which good quality embryos on day 3 to which arm. So the proper randomization should be per patient, not per oocyte. This will really tell the story. If all the oocytes of the patients and all the embryos of the patients of the same patient who are randomized is put in each arm. And the second thing, is it available in the commercially, this media with these additional things?
No, it is not available commercially to my knowledge, certainly not in the US.
Yeah.
But the randomization, they randomized at the time of, from the ICSI, from after the ICSI. So they did not randomize on day.
You said the day 3.
No, day 3 was the first assessment. So they randomized.
So they divided the embryos on day 3.
No.
So,
they divided the eggs on day 3. I'm sorry, they divided the eggs at the egg collection. And some of them, they supplemented the culture, and some they did ICSI on all the eggs, and then some of them, they supplemented the culture of the injected oocyte. And they just did an assessment on day 3. So day 3 was not a randomization.
So randomization was done on the PN stage.
Before that.
Oh,
Yeah.
Okay.
So they looked at different.
Okay. Another question to Professor Riz from Dr. Mohammed Al-Deeb. Do you think that adding antagonists to the culture medium is as good as asking the patient to use it as a medication 2 months before IVF?
Adding antioxidants, you mean?
I mean, yeah, antioxidants. Sorry, yeah, antioxidants.
Yeah. So I don't know. I really don't know.
Yeah.
because again, it's very difficult to compare things that are not at all similar. And again, I mean, you know, tremendous amount of effort was used by those investigators in determining how much they added to the culture media. Similarly, for us to come up with an antioxidant to be used, it took a lot of effort. Then now you cannot change that antioxidant to do the study. So in a way, you are dealing with certain railroads that have already been developed.
Yes. Okay, may I, you know, Professor Risk, probably that we have the Myoxic system and that we're using it for some of our work. And
Yes,
my question is, you're probably aware of the paper of Ralph Henkel, where he's talking about reductive stress. So maybe, you know, following this, I mean, if people ingest too much antioxidants, they may shift things to the other side of the spectrum. They may end up by having reductive stress. And this is again a question about how do you make the measurement, how do you calibrate the amount of antioxidants you add to the culture medium? They probably did, but it's something that you bear in mind.
You're absolutely right. You're absolutely right. And like you said, with the Myoxic, it was very easy to measure on the seminal plasma and so forth. However, on the eggs, are you going to measure the blood, the serum of the women? Are you going to measure the follicular fluid of the women? Are you going to measure it in culture media from the granulosa cells? So it was actually difficult to do that part. We have actually two of the PhD students. One of them is actually currently she's doing her PhD at Cairo University, and it's a joint supervision that we're doing. But it was very easy to design the male infertility study. It's very difficult to design the female because of the assessment of the amount of oxidative stress. So you're absolutely right. And you can easily over-medicate. You can easily over-medicate.
Where is she doing this PhD? Where is this PhD?
She's doing it in Cairo University in the andrology department. Yes. I was just one of the supervisors of the thesis for her. And I think things just got a little bit delayed because of the COVID and all that, but hopefully we present to you at some point some of the data from there. She did it on the male side, and on the female we have a block road.
Yeah, we also have a student who is doing a PhD. Anyway, Professor Awad, a patient 35 years old with unilateral OMA, 8 centimeters inside, severe pelvic pain. Would you recommend surgery or immediate IVF?
I would stabilize the pain if I can with a GRH agonist suppression. And then I would collect those eggs and cryopreserve them and then go for surgery. Now, alternatively, if the pain is due to, because at this size, sometimes the acute pain is due to leaks. Sometimes these ovaries would leak. And this is expressed usually by sudden rises in CA125. It goes from 80 to 200, 300, and it goes down, up and down with the leaks. At this stage, sometimes aspiration to immediate pain, and then stimulation, collection of eggs, and final surgery.
Yeah, I think we have many questions, and I don't think we'll be able to answer them all. But there are a few more. DNA fragmentation testing. Can we use antagonists for both IVF candidates routinely to avoid test cost? This is a question for Professor Risk. And which type of antioxidant do you advise for male and female?
Yeah, again, the DNA fragmentation test, there are many tests, and there are different kinds and so forth. And this has led, like I showed one PowerPoint with 10 different tests being potentially involved. And this is where, for example, the Myoxic has been recently favored in the US because of a standardization study between 12 andrology centers, that all those centers were happy to do it. I think, please go ahead. No, I'm fine, thank you.
A question from Dr. Anu Shaula. Dr. Riz, on what grounds did you decide to choose these 3 antagonists?
There are not many that are available to choose from, and it was very difficult for us to make a new concoction, if you want to say. So we had to choose between the ones that were available, and this was the most logical. So for example, we in the IVF lab study, they are just adding individual ingredients like N-acetylcysteine into a culture medium. For us, we're not going to compose a group of antioxidants to start an individualistic approach. We had an array of a small number that are available in the US, and we chose the ones that we thought would be the best, the best ones that serve the purpose.
Yeah, thank you very much. I think there is a question from Dr. Bushra Al-Musawi. I think she's from Iraq, and she's asking about the best protocol for endometriosis, and I think Professor Awad has answered this. What about Visan treatment for endometriosis? Of course, Visan is good for pain, but we are talking here about infertility. Dr. Assam Khalifa, who is a professor in Asyut University, he's thanking Professor Aburgar, is asking about the old technique, autologous endometrial co-culture that prove a better outcome in repeated implantation failure. And he's quoting a reference by Dr. L. Saint, 2019, Reproductive Medicine Online. And also a paper by Martin Estaria proving significant improvement by zona thinning. So what do you think about these two techniques, co-culture and zona thinning?
Well, co-culture was used extensively from the 90s in different publications, different types of co-cultures. And finally, everybody gave it up because there was no proof that it improves pregnancy. And zona thinning, again, we published a paper on the zona removal, infertility and sterility a long time ago, but all this can produce a small increase in the pregnancy rate in the smaller studies. But if they are used in a larger randomized studies, then the effect is not there. So I think that all these techniques should be done within, and the co-culture and all this within a framework of a study, not as a technique to be used in real practice.
Yes, thank you, sir. Dr. Rukaya Nayes, I don't know where she is from, but is there any role for Visan before IVF?
Our randomized trial, again, is on this as well. So it is registered already on RCT. We're looking into this to just compare this and no treatment and GRH agonist as well. So we do not know the answer yet.
Yeah. Dr. Rania El-Abani, Dr. Awad, Professor Awad, you mentioned surgery can reduce ovarian reserve and response to ART treatment. Any data about the time frame ART attempt was done after surgery? As it had been previously suggested that surgery has a short-term negative effect compared to a better long-term effects afterwards. What are your thoughts?
That's very true. But now most of the AMH were measured after 6 months. So this is the time where the ovarian reserve stabilizes after surgery. But the harm is well documented. We cannot deny it.
Yes, sir. Dr. Hassan Youssef, who is the founder of the Middle East Fertility Society, one of the original 6 founders. We are very pleased that he is with us, and he is asking about what about freezing all the embryos in endometrioma. And I guess it's for your good self, Johnny.
Yeah, I do not think we have evidence to support this practice. On the contrary, I think if the patient is not symptomatic and she can go ahead with fresh transfer, certainly we go for a fresh transfer.
Okay, I think another question maybe for Professor Abu Yara or Professor Risk. What options would the panel offer for patients with high BMI who need IVF but cannot or have even failed bariatric surgery?
Well, if the patient is young, she must lose weight. There is time to lose weight, whether by dieting or by surgery. But if the patient is close to 40, then she should start the IVF irrespective of her weight.
Can I comment on this?
Please.
Yes.
I think the UK has been very picky about weight, pre-IVF, control of weight. And I know many centers in the UK would send the patient back, tell her, lose weight and come back. And this is based on epidemiological studies that have shown that women who with high BMI do have a lower chance of getting pregnant, and that losing weight in as much as 5 to 7% of the body weight can improve spontaneous pregnancy. However, we have several studies, maybe 3 or 4 randomized trials, that showed that when a woman is subjected to a weight-losing protocol, these are randomized trials, and they do lose weight, it did not impact or improve their chance to get pregnant with IVF. So the evidence so far did not show that an intervention to lose weight will improve IVF outcomes. Spontaneously, certainly we have epidemiological studies to support it. And that's why the problem is when a woman has been with a BMI 34 all her life, putting her under the stress of something she will never be able to achieve may be unfair.
Yes, sir. Okay. There's a question from Dr. Haikal Trabilsi from Saudi Arabia. Do we continue antioxidants during pregnancy, Professor Risk? During pregnancy after IVF?
No.
Lady, huh?
Certainly
no?
not. No, certainly not, because if you look at the doses that we have used, definitely could be, this is a totally different study to see if their impact on the early embryogenesis. So, for example, I give you some example, I mean, amount of vitamin A and so on, like 5,000 international units, the amount of, so for the water-soluble ones, the C and B, they will be washed. For some of the lipid-soluble, they could be retained. And to say the least, I don't know their impact on the embryogenesis. So I recommended that once the pregnancy test is positive, they go on the regular prenatal vitamins that they have been used for many years.
Okay, Dr. Risk. A question from Professor Amr Nouri, my predecessor, the former chair of the Egyptian Representative Committee, and incidentally, who is going to moderate, co-moderate next week's webinar. What would be your recommendation in an adolescent girl with bilateral large endometriomas causing pain with an AMH of more than 6 nanogram per milliliter?
Oh, if it's painful and it's non-responsive to medical treatment, surgery might be required.
Surgery
Now, if she is someone who is, you can dialogue with and advise her, not an adolescent, I would say if she's 18 and above, and you can really talk her through egg cryopreservation, I would, because surgical treatment is not a final cure. This woman is at higher risk for another surgery or another intervention. So cryopreservation is something I would strongly recommend. Of course, if she's above 18. Below, there is controversy on how efficient and psychologically acceptable it is.
Right. Is there any role, Dr. Karim Ahmed, is there any role for dopamine agonists in IVF?
In the context of moderate women at risk for moderate OHSS, probably yes.
Yeah, I mean, I don't know if there are any studies. I don't know.
Yeah, there is a Spanish randomized study which was published in Fertility Sterility, which shows that it reduces the risk of moderate but not severe OHSS.
Yes, sir.
As long as we withhold embryo transfer, because the impact is on the early stage OHSS, not on the late onset OHSS. So we can give it to women at risk of moderate OHSS as long as withhold embryo transfer and we freeze all. That's where the benefit is.
Yeah. I think this will be the last question because we have many other questions. Maybe we are going to collect them and send them to our distinguished panelists and then answer them back by email. Dr. Rami Assi is asking, does progesterone level about 40 nanograms per milliliter? I don't know if he means 4 or 4 the day of ET. Does this have a negative impact on the pregnancy rate? What would you do? Would you freeze and put it back or later, or would you still go ahead?
On the day of embryo transfer.
Yeah.
On the day of embryo transfer, right?
Yeah.
Yeah, I think he's alluding to a study that showed that when it is above, I think 30, 35, on one, less than 10 is associated with a lower outcome, right? But there's a single study that showed on the other extreme, it is associated with lower implantation, but this has not been supported by other studies. I think this is what he meant.
Yes, sir.
I can answer this question, Professor Salam. Also, I give another answer. There is no convincing evidence that high level of progesterone affects the outcome of pregnancy if we do fresh embryo transfer. One of the reasons of this is that the level of progesterone varies many times during the same day. And all these studies, they did not specify specific time for measuring the progesterone. And number two, still the techniques for measuring the serum progesterone can be in these low levels. There can be big differences between one technique or another. So far, actually this question cannot be answered because we don't have complete evidence to support whether this is really will reduce the pregnancy rate or not.
We were happy with this webinar. I think because I have reviewed most of the comments, it was a very interesting webinar. I would like to thank all the speakers, my dear mentor and friend, Professor Abulghar, the president of the society, Boutros Rezek, and my colleague, Johnny Awad, my friend. Thank you, Hassan, for this great idea of combining the work between the Royal College and the Middle East Fertility Society. It's been a great idea. It's great to have you all. And only a reminder that we hope after this lockdown, the COVID, we'll see you in our next meeting in Amman, 3, 4, and 5 December. So thank you very much, and looking forward to see you and to have you again.
Thank you.
Thank you very much, Dr. Michel. Bye-bye, everybody. And thanks again to Mina Farm for hosting us on their platform in today's webinar. And thank you, everybody. And a la prochaine, as we say in our part of the
Hasta la vista.
Hasta la vista, hasta pronto, hasta next
Hasta
week.
la próxima semana.
Okay. Bye-bye.
Hasta la próxima semana. Okay. Goodbye. Bye-bye.
Bye-bye.